Hello everyone, my name is Alex Miller. I am here to present about Medicare leaving patients behind. Now, don't let that scare you. It's not physically leaving patients behind. This is to go in depth on how Medicare basically does not assist patients further with coverage. So when we think about retirement, we think, bliss, relaxation, comfort. We've all worked so hard for many, many years. Maybe we've worked for 30, 40, 50 plus years and, we save so that we can relax and enjoy the rest of our time. And well, with that, we put in so much money towards our retirement, right? So each paycheck each month, we're putting in money and, well, it's just going towards taxes, it's going towards Social Security. And in the end, we're told, hey, we have insurance coverage, Medicare actually. And we're very hopeful for this because, when you work so hard for something and you put your money, not all of your money can be given to yourself. So you have to, give some of it away to other funds, and it's not really by your choice. We're hoping that we're going to be taken care of in the end. Well, that's why I'm here to tell you otherwise. Basically, Medicare does this thing where they have started to, and it's not recent, it's actually from 2010, Medicare decided to place in a law or policy about how they wanted to restrict the amount of readmissions that were in. So imagine yourself, you're in the hospital, you're there for a heart attack, you're there for a stroke, you're there for knee repair, a quick medical procedure that doesn't require you to be in the hospital more than 24 hours. And you have a gal come in and tell you, hey, I'm from admitting and I'm here to tell you that you're in observation status. And you look at that gal and question, what do you mean by that? Well, your doctor has a choice. They either have to place you in observation status or you stay longer and they actually admit you into the hospital as an inpatient. Well, you'd be confused, right? Because you think, hey, I am a patient in a bed. What are you talking about, inpatient? I should already be inpatient. Well, actually, that's where things get slippery. So when you're placed in observation status, Medicare doesn't quite cover what you think it does. Think about it this way. Medicare has Medicare A and B, and you can have supplemental coverage if you decide to pay more out of pocket. Most people can't afford the out-of-pocket coverage, so they just stick with their regular Medicare coverage. Well, with that, Medicare A and B is your basic free coverage every month. With A and B, A is only for inpatient, B can be for all sorts of care. So Medicare Part B is not really necessary for this, this portion of the slideshow, but Medicare Part A, when you are in observation status, technically you're an outpatient, so Part A does not cover your stay because Part A, again, is only for inpatient. So when you have an outpatient person come in and they're in the hospital in a bed, but they're placed in observation status, Medicare A does not cover that part until the doctor places you as an inpatient, not an observation status. So the gal that goes in to tell the patient about that, well, they're the ones informing the patient, hey, Medicare Part A isn't covering, so only 20% of your stay today or while you're in the hospital is covered. You're required to pay 80% out of pocket. Well, the patient gets confused, they don't understand. They didn't even know this was a thing. So with the law being set into place to have patients be placed under observation care to reduce readmission rate. So this was more for patients who were abusing the hospital care system, the ones who are homeless, that are finding it to use as a shelter. And I'm not meaning that in a negative way. A lot of homeless people do need that shelter, but it's also the patients who are abusing drugs and alcohol, or there are patients who will come into the hospital because they're bored, and so a lot of the times they'll try to find a way to be admitted. It's the patients who abuse the system again that are the ones who cause this law to be set into place to reduce the readmission rate. So that really killed it for the patients who do need the care, such as the ones who have heart attacks, strokes, knee replacements, short-term medical procedure care. Those are the ones who are suffering, because the ones who abuse it, you really cannot separate the two, and you can't put stipulations on one or the other. You have to be fair to all patient care. And so in reality, it's necessary to have patients have the coverage for Medicare versus not, and to cause patients who are on a fixed income or who are lower income to have to pay 80% of a hospital bill because they had a heart attack or they had a stroke. It's not fair to those patients. A lot of the time health conditions occur and we don't have a choice. Our body just does what it wants to do, and we have no control over that. And so to require geriatric population to pay more than they can afford isn't fair, and it's not necessary. And there needs to be a way to figure out how we can take that away from these patients and take that burden off these patients. So outside of observation care and inpatient versus outpatient with Medicare, if we look here, Medicare, this is where Medicare beneficiaries are spending, and this was back in 2010, so you can imagine how much the increases happened in over the past 11 years, Patients are paying high amounts, and services are increasing with inflation costs and everything costing more now than it ever has, especially with medical care and because of COVID. You can imagine how much it's costing the geriatric population to pay out-of-pocket expenses. Now, think about it this way. It's not just because they're on observation care, it's medications, because there are times where medications won't be covered. There are times where specialty office visits will not be covered, and Medicare has to find a way to tell the patient that they're not going to be covered for certain things, and it's just costing each patient every month more and more money. Why can't we just give these patients the free coverage that they deserve? As you get older, you need more care, and a lot of the times, patients who had medical coverage from employers but can't afford to have the coverage because they're retired, they rely on that coverage, and they could have been really healthy prior to retiring, but they have to lack now on their health because they cannot afford to pay the out-of-pocket expenses. Now, again, I said supplemental insurance earlier. Supplemental insurance is quite expensive. It's another monthly cost that patients have to pay. And again, if you're a lower income, fixed income patient, you can't afford the $200 to $300 extra to have a supplemental coverage, because you could have other things that you're paying for, like being in an assisted living home, or needing to help support your kids, or you're paying your mortgage, or you have to pay your car bills. There's so many expenses out there, and to have patients who've worked so hard in their lives have to pay more for health coverage, it just baffles me. So finding a way to be able to assist these patients, and maybe Medicare needs to offer some rewards or some benefits that, hey, if you stay up on your treatment and you stay up on your physicals and your daily health, we will offer free care in a hospital, even if you're an observation patient. If you're willing to take the steps to take care of yourself and be an advocate for yourself, then we will help you in the long run. Because again, not only is it going to fall on the patient to pay, but it's also going to fall on the family members to pay if the patient can't pay. It will fall on the family to take care of after that family member is deceased. And so it's really just a domino effect of debt. And in reality, these patients aren't going to be able to pay the bills, and they're not going to be able to pay what they owe to the hospitals. And so being able to find a way to reduce that debt overall is going to be beneficial. So what I'd like to propose is, I think, creating a hospital team in each state and looking at the demographics, looking at the ratios, looking at the admission rates. Obviously in Oregon, Washington, California, New York, we're going to have a higher homeless population, so that's going to really inflate a lot of numbers. But looking at the age groups, looking at the demographics, looking at the diagnosis, what are these patients coming in for? What are they being seen for? How can we fix the problem, looking at the data, and then being able to present that to the government by saying, hey, these patients need help. This is the demographic type. This is the diagnosis. This is a percentage of homeless, and kind of not utilizing the homeless patients as a part of that, because they're so separate entity of medical coverage. They do need their own help, but taking that out of how geriatrics have to pay more would be beneficial to, overall spending from the patients, and, not requiring so much from them to pay for their health needs. Thank you everyone for listening, and I hope you all have a wonderful day.